Hi, I'm Alicia.
And I'm Robin, and you're listening to Bowel Moments,
the podcast sharing real talk about the realities of IBD. Served on the rocks.
This week, we talked to Dr. Megan Riehl. Dr. Riehl is a GI psychologist. She's an associate professor of medicine, and she's also the director of GI behavioral health at the University of Michigan. As you can imagine, we talked to her about all things GI and mental health. And we talked to her about how she established the behavioral health aspect of the IBD Center at the University of Michigan. We also talked to her about her interest in innovations in digital therapeutics and apps that she has used and recommends to patients. Finally, we talked to her about the book that she just published called Mind Your Gut, the science-based whole body guide to living well with IBS. And while this is an IBS-specific book, there are definitely some tips in there for people living with IBD as well. Cheers!
Hi, everybody. Welcome to Bowel Moments. This is Robin.
Hey, guys. This is Alicia, and we are so very delighted to be joined by Dr. Megan Riehl. Dr. Riehl, welcome to the show, and I think you've given me permission to call you Megan from now on. So, Dr. Riehl, welcome to the show, and I shall reuse Megan from now on.
Yes, thank you so much for having me. I'm very excited to be here with you guys.
We are so excited to have you. We were kind of laughing that we feel like we know you because we've seen you so much in the IBD space, and so we're very, very excited to talk to you. But our first very unprofessional question is, what are you drinking?
I know. And I'm not drinking anything fun right now. So I've got, I'm aiming for more water in 2024. So I'm chugging that, but I do start vacation in the coming days. So I'm going to manifest that if I were doing this podcast with you while I was on vacation, I'd either be having, a nice mimosa or maybe a little bit of bubbly in the evening. So something fun, it's all about moderation.
I love that. Robin, what about you?
Tonight, I am having a little glass of raspberry lemonade.
Well, I'm stick with my usual. I'm drinking a glass of Sauvignon Blanc, but I'm also drinking water as well because my goal every single year for many, many years has been to drink more water. And sadly, I fail pretty much every year, but I keep trying. So I guess that's good.
One of the benefits of the Stanley, craze is like, even if you don't have a Stanley, you've probably got some other ginormous water bottle that we're toting around. I love the Instagram posts of, the people hauling their trash cans to like make fun of the people that are carrying the ginormous water bottles. I know Robin's showing her water bottles. I forgot mine today, but the benefit is from a behavioral perspective is it helps, And so otherwise I get steps by like saying, okay, I've gone to the water fountain like 3 times to fill my cup. I need to go several more times. So, it's always a goal.
Well, I'm excited to discuss more behavioral modifications that we could be doing to improve our lives because I'm guessing you have more tricks up your sleeve. But next question for you is tell us your IBD story. Oh, I forgot to say cheers. Cheers, guys. I'm sorry. So cheers.
Cheers. To you.
Next question for you is tell us your IBD story. What made you decide to become a psychologist and why did you choose gastrointestinal disorders in particular?
Yes, this question is always one of those where it's like, how did I get here? I trained as a clinical psychologist, got my doctorate in Chicago. I saw a vast diverse spectrum of really spanning socioeconomic status, diversity, equity, inclusion, age, when I was training to be a clinical psychologist. And then fellowship came around and there was an opportunity at Northwestern University in their GI division for a behavioral health position. And really long story short, I got that position, trained with Dr. Lori Kiefer and Dr. Sarah Kinsinger. I did 2 years there, but really in my first year was already starting to talk about creating a program at Michigan. And so I rolled right from my fellowship into becoming the director of the behavioral health program at the University of Michigan. And I've been there 10 years. And kind of from there, this career has emerged. What keeps me here is that I see patients with a variety of digestive issues. So a lot of patients that have IBS, irritable bowel syndrome, and then a lot of patients that have IBD. And each diagnosis is different just as much as every patient that has that diagnosis is different. So the first couple years of my career, I kind of felt like I was in medical school. So if I'm perfectly honest, when I went into that interview for fellowship, I didn't know the major differences between IBS and IBD and what GERD really was, heartburn. And, I faked it till I made it in a way. And so then when you start to kind of identify, okay, if I'm working with patients that have IBS, I can implement behavioral strategies that are evidence-based, and I might be able to help them significantly improve their coping, the frequency, the severity, the duration of their symptoms. And I can do that in a fairly short period of time of therapy, anywhere from 5 to 7 sessions, and I might not ever see them again. And that's wonderful. That means that their life changed and their health has improved and they get to go off and live life. And then with patients that have inflammatory bowel disease, I might apply some of those same behavioral strategies, but based on what's going on in their life with their disease, I might work with them for a couple of months and then never see them again. But more times than not, it's more of this kind of like I'm on retainer, like an attorney, where you might establish with me for an initial treatment plan. We set goals. We're working on, really honing your management skills, and you might be doing really well. Go live your life, but then maybe you're off to college, or maybe you are making a big move, or maybe you're getting married, or maybe you have been told you're going to need surgery, or maybe you had emergency surgery and you're coming back going, I don't know what the heck just happened, but I am not well. And we have to work through that. So working with patients that are living with IBD is incredibly rewarding. And also over the course of my career, I have found I'm really passionate about educating. So educating providers about how talking with your patients about their psychological, emotional health is just as important as their physical health. And doing that in a way that highlights the evidence of, the strategies that we can employ as clinical psychologists or mental health providers, giving them tools and strategies and how to maybe use some motivational interviewing or shared decision making with their patients. And also just tangible resources like teaching diaphragmatic breathing or muscle relaxation. So I've had really the privilege and the pleasure of being on at a lot of different national conferences, speaking and educating, and also participating, with the National Crohn's and Colitis Foundation on various kind of committees and at different levels that have just kind of escalated over time with my involvement. And I am so inspired in those situations because I'm also then working with my colleagues. I'm sitting at the table at Crohn's and Colitis Foundation meetings where we are talking about how do we make life better for people with IBD? What are the gaps? What are the areas that we need to improve? How do we do that? And that's really, another side of this career as a GI psychologist that is exciting and really part of why I'm here.
That's awesome. And yeah, we are big proponents of mental health and mental health being incorporated into the whole GI care space. I am curious, when you went to go build this program, I'm curious, what were the expectations of the people that were already in the group that you were joining? And curious if there was any reticence on anybody's part to be able to incorporate this in, because one of the things we've said is, once you start having conversations with patients, once you open the door, it's hard to close it. And and so you're having to retrain people to really open doors that maybe they have not been inclined to open before because they didn't have the resource. So talk a little bit about building the program within an existing program.
So at the University of Michigan in our GI division, between fellows and faculty, there are almost 100 gastroenterologist providers, which is usually about like the second largest in the country. So when you're building a behavioral health program within a division like that, there's a couple of fine lines you have to walk. So number one, there's no way I could have 100 people referring to me. And then number two, I need people to refer to me. So I need to educate a small group of stakeholders that are most interested, that are most invested in, who are the appropriate referrals? What is this going to look like? This is GI specific behavioral therapy. This is not your general mental health provider, pathway. So, if a patient is suicidal or is, severely anxious or depressed, I'm not the person for them. So there's a lot of coaching around that because they just hear clinical psychologist, great. Like we need one of those. And so when I first came in, I was very fortunate that there was a wonderful group of stakeholders. So who's now our division chief, Dr. Bill Che, he and I really built the program together. And it was through his advocacy, and he really is such a champion for the work that we do in both behavioral health and nutrition. Our business manager at the time also played an incredible role, Jeff Holden, because, somebody has to pay the salary and proof of concept. And I had to create a business model for this to show them like it might be a red line initially in your budget, but look at all of the things that we can do to help your providers to maybe reduce a little bit of physician burnout. Meredith Craven at Stanford right now is doing some research looking at the benefits of having a psychologist in an academic practice. So that research is starting to emerge around these benefits. But I will never forget, I was at a Women in GI within our GI division at Michigan Medicine. We were having a kind of get together. And one of our more senior faculty basically looked me dead in the eye and said, I'm going to have to scope more to pay for your salary. And I didn't know what to say except, thank you. Great. I don't know what to tell you. But my personality is I'm a hard worker, and I had a feeling that I would show proof of concept. I had a strong feeling that if we built it, the patients will come. Another thing that people said was going to be a barrier was just the logistics of showing up at my office location in downtown Ann Arbor. And to be very honest, I give my patients credit back then because, our appointment time was an hour, but when you took into account commuting, parking, navigating the hospital to get to my little office, a lot of times a 1-hour visit was a 3-hour commitment, and yet people did it. And they completed their therapy. They continued to come, sometimes, weekly. And within my first baby, so I've had 3 children and I use them as benchmarks. So I started in 2014 and I went on maternity leave in October of 2016. When I left for maternity leave, I had over a 6-month wait list. When I came back, I had up to a year to get into our service. And many of the providers that were even just a little skeptical were like, you were gone for 3 months. Where were you? We couldn't wait to have you come back. So, I think that for maybe mental health providers that are thinking about going into this field, because the Lord knows we need you. We need more and more people interested in providing this type of care. It does take, hard work. It takes some resilience. And then it also takes working with your physician champions to create a really strong foundation of, a referral pathway.
I hate that you had to do proof of concept with folks, but I love that you did get folks to really come around eventually to understand that this is such a vital part of your practice. I'm curious, as you're looking at your research topics and as you're looking at topics to be able to educate the other providers on, one of your papers that I found was about trauma-informed care around very specific exams and things like that. Can you talk a little bit more about what got you involved in that and how do you handle this as you're working with the providers within your group?
Yes. So one of the things that got me into this is the growth of our program at Michigan. So I created a fellowship for clinical psychologists. And the first person that went through our fellowship is Dr. Christina Jagelski. And she is such a gift to this field. So she completed fellowship and we hired her on as our second GI psychologist within the division as a faculty member. And as she kind of got her feet settled as a new licensed clinical psychologist and in this very specialized area, she really kind of came to the conclusion that she's very interested in trauma-informed care. So through supporting her and really kind of trying to give her the resources to explore this and do a little bit of research in this space. One of her projects was a survey study looking at just internally our gastroenterologists and how they were screening for trauma, how and if they were screening for trauma. So this was a pilot project that we did back in 2019. And we identified that about 50% of our gastroenterologists were screening generally, but about 70% were not screening prior to colonoscopies. And so, in addition to a lot of other things that we found in that pilot study, and she's continuing to do some really cool work in this area, and this will help inform educational opportunities for gastroenterologists in trauma screening. I've learned a ton from her. And also, I've given some talks just even bringing up, do you ask about trauma? So one of the recent papers that she was the lead on, I think is great because it gives a little bit of a primer for gastroenterologists to think about some of these concepts of, are you screening between, ahead of these very intimate procedures? These are sensitive procedures, even just an abdominal exam, for somebody that is maybe a sexual abuse survivor, may be very traumatizing and might be considered even a secondary trauma if we're not careful about consent and describing what we're going to do with a patient. And so we wrote a paper and give gastroenterologists even some scripts on, asking about trauma. And then also if they do screen positive, so if they have any history of trauma, asking, what might we be able to do to make you more comfortable prior to this procedure or prior to this exam? And I've worked with patients in the therapy setting where we talk about, man, it looks like, Dr. Higgins has recommended that you get a colonoscopy. And I see that it's been 2 years and we still haven't gotten that colonoscopy. Let's talk about that. What's going on? And we know that in the experience of post-traumatic stress, which up to 30% of patients with inflammatory bowel disease have symptoms of post-traumatic stress, re-experiencing and avoidance, could be medical avoidance, are really common symptoms. And so when patients are avoiding certain aspects of their medical care, we got to start to peel the onion to see why and what's contributing. And then how do we work together as a team to meet that medical need and to make that patient feel safe, to make them feel heard? So I think that in this field of gastroenterology, there's a lot of work that we can continue to do in the education space, because gastroenterologists will admit, they didn't receive trauma-informed, training regularly. Maybe they got one, or maybe they, went to an institution where they made that a priority or the curriculum was developed. But, there really is not a ton of curriculum out there, and especially as it pertains to GI, which is kind of shocking. And that also was part of, as Christina was diving into this literature and even the survey, we were like, there's like one study that helps us inform like what we want to ask. And so you're going to hear Christina Jagelski's name when it comes to trauma informed treatment and education in gastroenterology. So I get to just learn from her and support her. And also just because of that, it informs some of the ways that I educate providers too.
I don't want to steal Christina's thunder because hopefully we'll get to talk to her about it. One of the things you also specialize in is disordered eating. This is another thing that has come up pretty regularly on the show, especially when we've had some fantastic dietitians on as well. So talk about your interest there and what you see from the patient side.
I can answer that question. I just want to kind of clarify that. Okay. I wouldn't say it's like my big area of expertise. So okay. I think when we think about disordered eating, part of, again, it's very educational, is that so often in GI, food is tied to symptoms. And therefore, if we aren't conscious of a patient's relationship with food and why they may be avoiding food and how that can very quickly lead to a slippery slope of I only eat these foods because my belly can tolerate them, to I only eat dinner because I want to be able to go through my day without having symptoms. So I just come home and then I eat dinner, to now I'm doing that multiple times a week and progressing to disordered eating, which is, there are red flags going off, but then it can progress from disordered eating to a full-blown eating disorder. And that's where we then have to worry about, the malnourishment of that patient, refeeding syndrome, and also, the body image complexities that go along with eating disorder. So Kate Scarlatta and I wrote an article together about, highlighting, hey, as a psychologist, it's kind of my role to be aware, asking the questions about, does food cause anxiety? Are you anxious about the foods that you're eating? Are you anxious to eat because you're afraid of symptoms? Are you avoiding foods because of, a GI issue or your physical health? Or are you avoiding foods because of a body image concern? And that also starts to give me insights into treatment planning. So I'm not an eating disorder specialist. So if somebody has an eating disorder, I'm going to refer them to a clinical psychologist that specializes in eating disorder. But my job is to direct that patient in the right kind of area of treatment. If it's more of this kind of disordered eating like ARFID, avoidant restrictive food intake disorder, which is avoiding food in essence to avoid physical symptoms. So it's not avoiding food because you want to lose weight or because of your body image. And we see higher prevalences of ARFID in the GI patient population. I may be able to work with that patient to expand their diet by taking a team approach with their gastroenterologist to really identify. So let's say this patient has inflammatory bowel disease. From a medical management perspective, are we doing everything we can to optimize their health? From a nutrition perspective, are they connected with a GI registered dietitian who can guide them on, proper nutrition therapy that makes sense for them given their diagnoses, comorbidities, current symptoms? And then my role may be to kind of decrease some of that health specific anxiety around eating and maybe utilizing some behavioral interventions to give them other coping strategies. Because after we eat, sometimes bloating and gas is normal, but due to visceral nerve sensitivity, that might cause more pain. And so we can use some of our brain gut behavioral therapies to help address that brain gut dysregulation. But in those instances of disordered eating, it's really important to take that team approach and then escalate it up to more comprehensive care if that patient is starting to lean more into an eating disorder. So, while not necessarily my area of expertise, it is again another area where I encourage physicians to ask patients about their relationships with food. And a gastroenterologist may be the first person that a patient is disclosing that, like, yeah, I'm starting to avoid meals because it causes me diarrhea and the stomach pain is just too much. And so if a physician isn't kind of keying into, I wonder if they might benefit from talking with one of our psychologists about some of that anxiety, or maybe a dietitian to kind of discuss dietary strategies, and also just to educate the patient that, we need you eating. Avoiding food is not going to be part of the treatment plan here. So we want to work together to kind of meet your needs. And I think that's a really important thing. And especially as more research in kind of this ARFID and GI space emerges, we need to kind of guide providers and also educate patients on, they could be mislabeled with an eating disorder when really their eating behaviors are very much tied to their GI condition. And they might then get stigmatized and afraid to kind of engage with the medical system because they've been mislabeled.
Yeah, it's almost like it's a safety mechanism instead of a disorder. It's not like you don't want to eat the food. It's just that the food is scary and hurts. And so it's a difference. You mentioned brain gut behavioral techniques. Can you talk a little bit more give us some examples of those?
So brain gut behavioral therapies are evidence-based psychological therapies that can be applied to patients living with GI conditions. And that's a kind of a fancy explanation for using things like cognitive behavioral therapy, gut-directed hypnotherapy, mindfulness-based therapies, I'd say those are probably the three most commonly used and researched in this area. And they all can address aspects of mood, health specific anxiety, visceral anxiety, meaning, we feel stomach pain and that ramps up our anxiety, which then worsens the stomach pain. So we utilize these types of therapy to create treatment plans based on the things that patients need and what they're dealing with. And I think that's one of the unique characteristics of a GI psychologist is that we're very, well trained in using these types of therapy. And so sometimes when I've worked with a patient, it could be patients with IBD or IBS or really any GI condition who has been told in the past, you should see a mental health provider. And maybe they didn't get the explanation of why. And so then if you go to a general mental health provider and they're not, they're like, oh, you have anxiety and depression. Let's dive into your childhood and let's talk about this. And no shade to the general mental health providers out there. But I think that what our patients feel comfortable with when they meet a GI psychologist is they're like, oh, I don't have to explain what IBS is or what IBD is or what the difference is. You aren't assuming they're the same thing and you understand some of the nuances of this. And then we can go into the ways in which, somebody's psychosocial experience with life is impacted, as well as this recognition that, especially in IBD, there's a bidirectional relationship between IBD and mental health. So your IBD can impact your mental health and your mental health can impact your IBD. And so it's impossible to navigate without addressing both. And we use those brain gut behavioral therapies to help with that.
It must be a bit of a barrier for folks to really trust because, especially, I hate to say this, but in general, when women go and start complaining about having stomach issues, there's a lot of it must be mental health related. There's a lot of dismissal that happens. And as part of that dismissal, it's like, oh, we were just not coping with your stress very well, or you must be depressed, or, these types of things. And so I would imagine there's a little bit of that barrier when people engage to be able to really trust that this is not just them getting put off again, so yeah, sorry. I was thinking about that as you were talking. I'm like, how many times have women's especially, their symptoms been dismissed as just in your head?
Yeah. Well, I mean, a lot of patients have been, especially, people with IBS, they're told, hey, we did your colonoscopy or we ran your labs. Everything's normal. Good luck. And I think the good news is we have moved the needle, in terms of at least now there's less of the it's in your head. There might still be we know that there's a brain gut connection and that, a variety of factors can impact that and that addressing things with a behavioral health, psychologist or therapist is helpful. We don't have access to one, but it could help if you could find one. So we are moving the needle a little bit more. Our field needs to catch up, but my heart breaks sometimes when I'm sitting in an initial consultation with somebody who has had IBD for 30 years. And they're like, where were you 30 years ago? I needed support. And, so I'm hopeful that with time, more and more of that support will be offered at the onset. And that's also another kind of moving the needle type of experience where it's not, we've tried everything and now you need to go see a GI psychologist or you need to go see a psychologist. Gastroenterologists in our field are now accepting that, we've given you a diagnosis and I've offered you everything I can. Your treatment is behavioral health. And that's going to be helpful for you. And when you can present it in a confident way as a part of your treatment plan, that you as the gastroenterologist are still a part of the team. It's just that right now you don't have the ball. You've passed the ball to somebody else and, you guys are running down the field together. That makes a big difference in terms of how a patient feels, both their relationship with their gastroenterologist, but also in terms of their overall holistic care.
Can we expand a little bit on, you mentioned earlier IBS and IBD? Well, you mentioned that in your story, but you mentioned it a couple of times. Can we talk a little bit more about the overlap between IBS and IBD? Because for some IBD patients, not me, everyone listening, not, but for some IBD patients, there is a little bit of they don't like the mention of together, right? Because IBS is not an autoimmune disease. It doesn't have the same implications on your system, the medications, the surgery, all of those things are not the same, right, for IBS and IBD. And so there's some of that feeling of, what are those memes that go around? What is one thing that you never say to an IBD patient? Oh, I know what you're going through because I have IBS or something like that. So I just feel like there is a lot of overlap. There are a lot of IBD patients that also have IBS. I feel like the symptoms that people with IBS have are very similar to symptoms that we have with IBD. And I feel like there's enough compassion for us. There's enough compassion to go around for all of us. But I know that you do a lot of work in both settings and that you just recently published a book. So could you talk about the overlap and your book and that all just together?
Yes. So, yes, I will be very clear that they are two very separate diagnoses. However, there's really interesting research that shows that. So, number one, when you have an IBD flare, symptoms of anxiety, depression, chronic pain, insomnia, everything, the prevalence increases. Everything gets worse when we're flaring. We see rates of anxiety and depression compared to the general population higher in patients that have IBD and also in IBS. But when a patient is in remission and they are still having symptoms, and this could be endoscopic proven remission, clinical remission, and they're still having symptoms of abdominal pain and diarrhea, first thing you do is you call your gastroenterologist and you're like, what's going on? And the reasonable thing to do is to do some assessment. So they might ask for a fecal cal. They might run some labs, depending on when your last workup was and the severity of your symptoms. That's going to inform the workup that they suggest. But let's say they do a very thorough workup and your disease is still in remission and you're still having those symptoms. I think it can be so validating for patients to understand this overlap. Because then it makes sense. Okay, my disease is in remission. That means I need to keep taking my medication. I need to keep doing the things that I'm doing because it's keeping me in remission. But I also can look over here at other maybe behavioral strategies that can help with symptoms that are related to IBS. And so we see anywhere from 40 to 60% of patients with ulcerative colitis and Crohn's disease have this dual diagnosis that can take place. And we also see that, anxiety and depression rates of somebody that's in IBD remission but having IBS symptoms are very similar to a patient that has IBD that's flaring. So those severity rates of anxiety and depression are similar. And then a patient that has IBD in remission that doesn't have that IBS overlap, their levels of depression and anxiety are lower. So what that means is that, it's kind of a double whammy with IBD because it really just highlights the importance of having a support system that can help you make sure that you are, having strategies to help mitigate effects of stress. So what does that look like? Working on your sleep hygiene, adequate hydration, eating a nutritious diet, exercise when you feel up to it, practicing, meditation, relaxation. I always say I could go a whole hour with you guys kind of talking about like, how do we find your feel good stuff? Because we all need to have it. And my stuff might be different from your stuff. And that's why as a therapist, I'm objective. It's not about me. It's about finding what works for my patient. So we look at that area of health. We look at, utilizing gut-directed hypnosis. I love giving this to patients that have inflammatory bowel disease because there actually is one study that showed that it prolonged remission rates in patients that had ulcerative colitis. But what it does is it works at that brain-gut axis. It works to address the communication pathway between what your gut is sending up to your brain and how closely your brain is paying attention, which can cause pain and cramping and spasming and urgency, constipation. So being able to validate for patients that your IBD is real, you have IBD, there are a lot of different things that may even exacerbate IBS symptoms. Maybe there's nerve sensitivity from surgery, and there's a lot of anxiety about, I'm having symptoms. How the heck do I know it's not a stricture? How do I know there's not something more going on there? And having a therapist to be able to walk through, all right, let's look at the facts. Let's look at the communication with your doctor. They think that this is the right treatment pathway for you right now. If things change, then we're all going to work together to address that. So I think that a lot of times, more often than not, if I can describe things in that way and check in with how that feels for the patient and answer questions, then more times than not, understanding that is a benefit, as opposed to feeling like this person doesn't understand and I don't want to go that way with my treatment plan.
That's helpful. Thank you. And Robin mentioned your book. You just recently published a book called Mind Your Gut, the science-based whole body guide to living well with IBS. Tell us about your book. What prompted you writing this? Tell us about kind of what's expected in this book. And you mentioned you thought there were things in it that would be helpful for our IBD folks in addition to our IBS folks.
Yes. Thank you for bringing up my book, baby. I co-authored this with, world-renowned expert dietitian Kate Scarlatta, and there has been a lot of fun. Writing a book is a huge undertaking, but what prompted us to write this was that, number one, there are certain strategies, interventions that we talk about with our patients in our everyday clinical practices where they kind of have these aha moments, like learning diaphragmatic breathing and being able to apply that in the setting of urgency or constipation, and then actually having change and benefit and feeling like, oh my gosh, I have a tool that's always with me that I can use. Having things like that I just feel like once somebody gets that, it improves their life. It improves their quality of life and how they manage these symptoms. And she has 1,000 of those examples as well. And so we thought, when it comes to access to these types of strategies, it's still really limited. And there are 45 million Americans with IBS, and the number of people that have other disorders of gut-brain interaction is increasing. So why don't we spend a year and put together 10 chapters of nutritional, behavioral strategies that are approachable, that are easy to read, easy to apply, but science-based, and put together this resource, not just even for the patients, but to help guide providers too. So the provider that talks with the patient about, man, do you recognize how tied your brain and gut is? And I want you to learn more about the stress cycle and how that can impact your symptoms, and maybe get your feet wet in some nutritional strategies, and also, some stress management interventions that can be helpful. Here is a book recommendation for you. So we did the work for them to put the resources together. And when it comes to patients that are living with IBD, again, we highlight these are different diagnoses, and the book is, living well with IBS. So we tailored things that way, but we have a chapter that's based on symptoms. And so again, if you're somebody that's following your medication regimen, your doctor is saying, we really need to work on stress management, or we really need to, maybe think about some nutritional strategies to supplement your treatment plan. We've got, again, the evidence-based information on everything from medications to supplements to, our thoughts on those types of strategies, and really taking, this whole world, which, what is the thing that we do oftentimes when we have a symptom, which we shouldn't do? Google, the internet. And you're likely, especially if you type in IBS or IBD, going to get 1,000 different suggestions that you don't know where they came from. So when you don't know where they came from and you're going to spend your hard-earned money because you're desperate to feel better, I would rather you know that the things that we wrote about in our book are backed by science and coming from, two experts in the field that have implemented our tools and strategies for a long time.
Very cool. I think it'll be really interesting to see this book and see what you've written in there, because I'm sure there's strategies that would be helpful for folks with IBD for sure. One of the things you wrote on your questionnaire is that you have a particular interest in innovations in digital therapeutics. Talk to us about that.
So again, it kind of acknowledges that there are worldwide about 400 GI mental health providers. So that number, and that's not saying that even some people are doing research, some people are, the N of one in an academic institution, so they're not taking external referrals. Even in our own practice at Michigan, we don't take external referrals because we just can't handle them. So access remains an issue. And so with digital therapeutics like Nerva, which is a gut-directed hypnotherapy app that anyone can download on the internet, it's developed with insights from Dr. Simone Peters, who has worked at Monash University and is really brilliant in the space of GI research. And so she helped develop their protocols and their product. So it's a product that, again, is based in science. And what I love about kind of this innovative space is that now patients that maybe didn't have access to gut-directed hypnotherapy have access to it. Now, granted, there are still some, there's a digital divide, right? So lower income households that don't have great internet access or the funds to pay for an app, that's a whole nother talk that is relevant and an area that we have to acknowledge. But when it comes to spending money, I think that there are some products out there that it's worth it. So the Curable, and I'm not paid by any of these, so I'm just throwing that out there. Curable app is a chronic pain management app. And when we know that, up to 70% of patients living with IBD also are living in chronic pain, and here's a product that might help you learn some tools and strategies to better manage your pain that you can do from home at a cost, but, that's backed by pretty good research and pretty good outcomes. My role has been, I have done some consulting, but again, more educating to physicians that, hey, did you know about the Nerva app? And do you know about some of the other products that are available? So Mahana IBS is a FDA cleared product where you actually need a prescription to use this CBT focused app. And so a gastroenterologist has to basically write a prescription that your insurance company might cover to get access to this digital CBT app. There's another gut-directed hypnotherapy app that's also an FDA product that's also available. And so the go-to-market strategies for all of these products are different. It's an interesting time in the field because, tech is coming in to implement the strategies that me and my colleagues do every day. And so we better be at the table giving you information so that you're not hurting our patients. And so making sure that there's some education in terms of what products have been vetted and how they might help your person that's living with, a variety of GI conditions.
Super interesting. And I saw a talk, this is several years ago, about like utilizing virtual reality in like anxiety and pain control within hospital settings. It was kind of focused more on children, but I was like, this is so fascinating to me as it relates to just how you could be incorporating something so easy into kind of all of the different things, like as somebody's sitting and preparing to go into a colonoscopy, or as somebody is waiting to get their infusion treatment, or whatever it is. And so I think there's some really interesting things coming that people are researching right now that are, like you said, in that sort of technological innovative space.
Yeah, so Dr. Brennan Spiegel is really one of the pioneers in
That's
VR work. Okay, yep. In fact, over the summer, I got to test his VR program it's currently for IBS that will become available to the public later this year. And he's now starting to do some research in the IBD space as well, because it makes so much sense, again, from inpatient hospitalizations to, what patients have access to at home. And I'll say within the virtual reality space, so you have the headset on. Maya is the therapist in this VR program. And it was fascinating because it's AI driven and she's interactive. And so I was actually sitting next to Dr. Darren Brenner, who's a gastroenterologist at Northwestern. And he was really challenging Maya, really going hard in terms of his, made up ailments and his mental health. And it was so fascinating to hear this AI bot, giving him suggestions and how she, would course correct to get him the right services. And so where I stand right now is that I don't think AI is replacing me anytime soon. And so we need to embrace it. We need to explore it. I encourage gastroenterologists to download some of these digital products so that they know what they're about and what a patient might experience. Because at baseline, they're all going to have some kind of a stress management component to it, and we can all benefit from that. So in a way, you're going to benefit too. But I don't think these products are going away. I just think it's a matter of making sure that the right people are participating in their development so that we can help educate and get the products to the patients that really need and deserve them.
It's fascinating to me. I mean, I turned to an app when I couldn't get the care I needed. I live in a rural area for something else, just for it wasn't primary care, but it was something else that wasn't like a specialist. And so it was available via an app. And so I turned to an app for that kind of service that I couldn't get. And because I live far away from care, I mean, I do my therapy virtually too. I mean, it's not an app. I'm doing Zoom calls with my therapist. So
yeah, I mean, if anything came out of the pandemic that, we can do therapy via Zoom. If you asked me that back in 2016, when I was doing some pilot virtual therapy work, I said, I think this is great for my patients that live far away. It will cut down on patients that cancel because they are flaring or they're having symptoms and they don't want to get in the car for 3 hours. But I'll never have my practice be 100% virtual. Well, it's 2024 and my practice is still 100% virtual.
Yeah, I think I live in the same city and probably not very far away from my therapist. I still meet with her virtually. Like, nah, we're good. Because then I can literally, I can work up until exactly the moment I have my appointment. And then I can jump on and do other things right afterwards. Like you said, I'm not having to drive anywhere or figure out incorporating that in. But yeah, it is very good thing that came out of the pandemic for sure. Megan, I am so sorry to say that we are coming to the end of our time with you. It has been a little while. So our last question for you is, what is the one piece of advice you have for our IBD community? And since you are a professional, you can say a piece of advice for our professional community and or a piece of advice for our patient community.
Well, this works for both. Emotional health is just as important as physical health. So if you are a patient, then, let's normalize conversations about how somebody is doing from an emotional perspective. And when we normalize those conversations, we feel more supported, we get more support, more resources are likely to be available. And so, even though you're not looking to your gastroenterologist to provide you with mental health treatment, if they're the person that's in front of you and you're struggling and you need support, let them know, and then they can do their job to get you that part of your treatment plan. So gastroenterologists or, PAs, our support staff, nurses, anybody that might be listening to the podcast, know that patients that have IBD are incredibly resilient. And even if their resilience is not all that great, we can grow that skill. It's a modifiable characteristic that with the right resources and tools, we can help a person kind of feel more empowered and more resilient, which will help them with the management of their disease. And so connecting patients with resources, knowing what those resources are, and really approaching health from a holistic perspective. That's my goal.
I love that. My follow-up to your final question is that you also have worked on some tools, some resources that are available to patients that may be searching for some tools. So would you mind talking a little bit about a couple of those tools? So I promise this is my last question.
So one of the tools is the book, right? So Mind Your Gut, available now. Another tool is diaphragmatic breathing demonstration. So if you Google my name and diaphragmatic breathing, there's a 4-minute video out there that, somehow it has become pretty well utilized. And I'm telling you, it's helpful whether you have diarrhea or constipation or cramping, or you just want a relaxation strategy. That's another tool. Another tool that I will kind of wrap up with is a podcast. So Kate Scarlatta and I just launched the Gut Health Podcast, and it's available wherever you find your podcasts. And every month we will bring on an expert, and we will myth bust. We will dive into nutrition and holistic health for both people that are interested in wellness and digestive issues, people that help people that have digestive issues. So I really think it's going to be another good tool to get your fill of science-based information from me and Kate Scarlatta.
Fantastic. That's so exciting. We love a podcast plug on our podcast. So we will definitely link to the podcast. All of the stuff will be in the show notes. So do take a look down there. If you're interested in any of this stuff, we'll make sure that we're linking to it down there so you have access to it. But Megan, thank you so, so much. It was such a pleasure to have you on the show and to get a chance to talk to you. Like I said, we sort of feel like we know you, but now I feel like we know you actually. So that's very exciting.
We're friends.
Yes, I love that. Anyway, again, thank you so much for joining us, Megan. Thank you everyone else for joining us. And cheers, everybody.
Cheers.
Cheers, everybody.
Hi, this is Dr. Megan Riehl. If you enjoyed this episode, please rate, review, subscribe, and share it with all your friends.